Most basal cell carcinomas are highly treatable, but they are not harmless. The exact site, subtype, borders, recurrence history, and patient context determine what should happen next.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. Okay, wait, hold on just a second. If you just said they are highly treatable, why can't a patient just ignore a basal cell carcinoma and go about their life? Well, to answer that, we really have to look at what this cancer actually is. So imagine the deepest row of your epidermis, that's the outer layer of your skin. That area contains what we call basal keratinocytes. Now, when we look under a microscope, basal cell carcinoma, or BCC for short, is a skin cancer made up of cells that look a whole lot like those normal basal-type cells. And the reason you absolutely cannot just ignore it comes down to how it behaves. You see, the word carcinoma actually means a malignant tumor that arises from epithelial cells. It usually starts out growing right there locally, but it can widen, it can extend way deeper than the edge you can actually see, and it can ulcerate and bleed. If it's left untreated, it can physically destroy the nearby skin, cartilage, bone, or even nerves. So the harm here really comes from local invasion and destruction, not from it transforming into a completely different disease. It is a cancer, yes, but it is not melanoma, and it absolutely, under no circumstances, turns into melanoma.
Building on that really crucial point, knowing the difference between these two is vital. Melanoma begins in melanocytes. Those are the cells that actually make pigment. Basal cell carcinoma, like we just saw, begins in a totally different lineage, the keratinocytes. Now, here's where it gets a little tricky. Sometimes a BCC might actually look brown or black because there just happens to be pigment present in or around the tumor, but that just describes its color. It does not make it a melanoma. An untreated BCC does not evolve into a melanoma over time. Now, sure, a person can definitely develop both of these as entirely separate cancers during their lifetime, which is exactly why having an exact biopsy diagnosis matters so much, but one does not magically turn into the other.
So what does it actually look like? Well, BCC has several different visual patterns, and honestly, it can mimic a lot of completely benign conditions. You might see the classic pearly or translucent bump, maybe with some tiny visible blood vessels and a rolled edge. Or it could look like a sore that just repeatedly bleeds and crusts over, but never seems to fully heal. But here's the thing, it's not always a bump. It can show up as a scaly pink or red patch that looks a lot like dry skin or eczema. It might even appear as a firm, white or waxy scar-like area with a really blurry edge, which is especially concerning if you've never injured that spot before. And, like we just talked about, it can be highly pigmented, appearing brown, blue-gray, or black, which is a feature you might see more prominently in darker skin tones. Because it can look like everything from a normal mole to a harmless cyst to psoriasis, snapping a photograph on your phone can definitely raise suspicion, but it absolutely cannot make or exclude a diagnosis. You need tissue confirmation for that. Okay, so let's say I get that biopsy you just mentioned, and my pathology report clearly says negative margins. Doesn't that mean the whole tumor is gone? Like, how do I actually know if I still need major surgery or just a simple procedure?
That right there is exactly the unresolved clinical conflict we need to dig into. See that number, 27.5%? That comes from a pooled review of 4 observational studies. In those studies, researchers looked at biopsy-proven BCCs where the shave biopsy specimen margins were reported as negative. But when those exact same tumors subsequently went in for definitive treatment, residual BCC was still found in 27.5% of them. That means over a quarter of the time, the tumor was actually still there. Why? Because a biopsy is just a sample. When a diagnostic shave biopsy says margins negative, it simply means no tumor touched the examined edge of that specific, tiny submitted sample. It does not by itself prove that the entire 3-dimensional cancer on the patient's skin is completely gone. So, to figure out what treatment you actually need, you just can't rely on the biopsy edge alone.
So to avoid undersampling a mixed tumor, and to make sure we're properly treating the cancer, clinicians have to carefully reconcile what we like to call the 3 clinical maps. First up is the clinical map. What's the exact location and size? Are the visible borders sharply defined, or are they fuzzy? Is this a brand new tumor or a recurrence of one that was treated before? Second is the pathology map. What is the microscopic subtype? How deep did the biopsy sample actually go? And is there any sign of nerve involvement? And third is the patient map. What is the patient's immune status? How's their overall health? And what is the real functional cost of this treatment for them? If these maps disagree, say your biopsy shows a shallow, superficial result, but your clinical map shows a firm, deeply tethered scar-like lesion, you don't just ignore that discrepancy. You have to rely on all three maps together to guide the right treatment. Because of those maps, not all BCCs are treated equally. We actually use specific features to place a patient into a specific risk lane. For status, a first primary tumor often points you toward a lower risk pathway, whereas a recurrent or persistent tumor bumps you into a higher risk pathway. Location is massive here. A suitable spot on the trunk or an extremity leans lower risk, but the head, neck, central face, eyelid, nose, or lip, those are highly tissue-sensitive areas and lean higher risk. Then you look at the borders. Are they sharply defined or poorly defined and scar-like? Pathology matters tremendously too. A nodular or superficial pattern usually supports a lower risk pathway, but an infiltrative or micronodular pattern, where the tumor forms narrow strands extending deeply, that is treated as way more aggressive. And finally, if tumor cells are seen invading a nerve, something we call perineural involvement, that immediately shifts the entire discussion straight to a higher risk pathway.
Okay, that makes sense in theory, but can you give me a concrete example of how this actually plays out in real life for two totally different patients?
Absolutely. Let's take two patients who both receive a diagnosis of basal cell carcinoma, but their treatment pathways are going to be completely different. Our lower risk example is a first, small, sharply defined nodular BCC on the upper back in a healthy patient. The clinical map is crystal clear, the pathology is predictable, and the location has plenty of extra tissue to work with. Now, compare that to our higher risk example, a recurrent, poorly defined, infiltrative BCC right on the nose. Here we have a tumor that has already come back once, it's growing in aggressive, narrow microscopic strands, and it's sitting on highly tissue-sensitive anatomy where quite literally every single millimeter of skin matters. Same exact diagnosis, completely different maps.
And because the maps are different, the surgical choices have to be different too. Standard excision is a really excellent choice for many properly selected, well-defined, lower-risk primary tumors. It works beautifully when we have the flexibility to just take a standard margin of healthy-looking tissue. Mohs surgery, on the other hand, allows for complete peripheral and deep margin assessment while sparing as much healthy tissue as possible. But here's the crucial point. Mohs is not universally required for every single BCC out there. It is highly valuable and frankly often preferred when high-risk anatomy, recurrence, aggressive pathology, ill-defined borders, or the vital need for tissue preservation materially change the patient's care.
Understanding your risk lane also dictates the practical urgency timeline. Look, most localized, lower-risk BCCs do not require a frantic trip to the emergency room. They are managed on a planned outpatient timeline. But keep in mind, planned does not mean you can just ignore it indefinitely. Now, for recurrent, aggressive, or tissue-sensitive BCCs, you really need prompt planning because any delay can enlarge the cancer and make the repair much more complicated. Then there's faster contact. You should contact your treating clinician immediately if you experience rapid growth, severe pain, numbness, weakness, or any symptoms involving critical structures like the eye or ear, immune suppression, or major local destruction. And in the very rare event of a locally advanced or metastatic BCC, it jumps straight to an urgent multidisciplinary evaluation.
So practically speaking, after absorbing all of this evidence, what are the exact neutral next actions a patient should take right now?
Great question. The very next steps are all about gaining clarity. First, make sure you keep a physical or digital copy of the pathology report and know the exact biopsy location on your body. Second, actually speak with your clinician to confirm the microscopic subtype, the exact wording of the margin, and the specific features that determine your risk lane. Seriously, ask them straight out. Which features make this tumor lower or higher risk? And third, agree on a treatment and a timeline with the treating clinician that gives you enough margin confidence for your specific site and your specific tumor.
Because ultimately, getting absolute clarity on your specific risk lane is exactly how you move away from panic and toward a solid, practical plan. So are you in the lower risk lane or the higher risk lane, and what does that mean for your next move? To really understand the specifics of standard excision, Mohs, and even non-surgical options, be sure to explore the next Skin Trust Explainer on basal cell carcinoma treatment options. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together